Good afternoon to Tuesday Topics. And today we're going to do something completely different. We're going to look at some simulation. You'll have to bear with me because I'll have to manipulate the simulator that actually shows us how our patient responds to changes in FiO2, PEEP, tidal volume, inspiratory time, and how it looks when we measure a plateau pressure and what we're really thinking about. Hopefully, this will go along with many of the talks that we've done on pulmonary and respiratory management and vent management and help us to have a really good and clear idea. So let me go ahead and share my screen. All right. So first of all, let me know, Eugenia, you can just give me a thumbs up or you can chat that you can see this.
I can see it.
Good, excellent. So what you're looking at now is a simulation screen from a vendor called Exelon. And Exelon is a Spanish vendor who for about 6 years has developed simulation models to help us have a better understanding of what's occurring with our patient. So we're going to take a short time today doing this simulation to actually apply a couple of different strategies that we've talked about. What you're going to see up here is some patient information, how the patient's breathing, do they have acidosis, where do they live, sea level or otherwise, and then some of the things about the patient in terms of their dead space, in terms of shunt, the patient's temperature, the pulmonary muscle groups, respiratory rate, static compliance, and some other components of information that's going to be here. I'm not going to manipulate any of this, but you will see it manipulated when I make some changes. Here, you're going to see his blood gases, and you can see where he is right now. He's got just a tiny bit below normal, 7.34 pH. His PaCO2 is 46, just 1 millimeter above normal. Bicarb is perfect, base is perfect, PO2 is 82, SAT is 95. We always have the ability to look at the PF. We're not going to do that right now. I'd like for you all to figure your PF. Remember, that's PaO2 divided by FiO2 in the decimal, and we can check your math. You can get your phones out, make sure you've got a calculator nearby. And here is what our patient is set on currently. So this is his tidal volume, his frequency, how fast or slow the gas is flowing. I'm going to put that up to a normal flow. Then normally it would come up at around 60. I was manipulating it earlier. This is the flow pattern, either that the flow starts and continues or it boluses and decreases. This is called a ramp. And then there's a second ramp that I'm not that familiar with. And then here is his positive end expiratory pressure. Remember what that means is that when the patient has taken a breath, the exhalation valves close at a certain point to maintain volume staying in the lung, creating positive end expiratory pressure. This is percent of atmospheric pressure that is oxygenated. That's the FiO2. The inspiratory pause and the expiratory pause are measures that I can make using hard keys on my ventilator that say inspiratory pause or expiratory pause. Inspiratory pause allows me to look at a P plateau. Expiratory pause allows me to look at what's known as intrinsic PEEP. That is gas that's trapped in the lung that is not participating in gas exchange particularly, and that may actually put your patient at risk for overdistension of their alveoli. The trigger is related to whether the patient generates a negative inspiratory pressure or changes the flow by inhaling, and then how sensitive the ventilator will be to the patient. I'm going to set that at 3. All the alarms are on. Here is what our patient is currently going to be breathing with. So this is his tidal volume. And then we're looking at his minute ventilation right here, his respiratory rate, and his exhaled tidal volume. And this is his peak pressure currently. Below that, we can look at P plateau, we can look at PEEP, and then we can, our total PEEP, and we can also look at drive pressure. Okay, so what I'm going to do, first of all, and again, because this is live simulation, we're going to work together. I should explain over here, which we're looking at vent graphics. So this is volume in and out, volume in and out, volume in and out. This is flow, how fast or slow you're delivering the volume. So flow goes in, and then it goes out. Flow goes in, and then it goes out, and it should always return to that zero baseline before the next breath takes place. When it doesn't, what happens is you end up with extrinsic PEEP. And here you're looking at his peak airway pressure. And then here you're actually looking at what they call PMUS, which is actually the exerted effect related to the musculature. And right now our patient isn't breathing. So now I'm going to start him breathing. You're going to have some small beeps. They should be quite light. I tried to turn them down, and you're hearing him take a breath. So right now our patient is breathing very nicely without a respiratory effort. And I'm taking a look at his blood gas. Okay, I'm the nurse. I'm looking at the blood gas. I'm thinking about what I want to communicate. And his pH is just a tad bit low. His PaCO2 is a little bit high. Bicarb perfect, base is perfect. His oxygen is a little bit low, but if I look at his P to F ratio, that takes his PO2 80 divided by his FiO2 0.21. That's a PF ratio of 382. Now, what that tells me is that if I would like my patient's oxygen to be higher because he has this PF that's greater than 250, we've talked about this a lot before, what I'm going to do is I'm going to increase his FiO2. So I'm going to increase them to 40%. And just like on the ventilator, I have to confirm I made that adjustment. Now let's see what happens. I've gone up to 40. Let's see what happens to my patient's PaO2 over the next few minutes. Okay, so what did I tell you? Your patient is an oxygen responder. Now you've got this beautiful PO2 that makes you really happy, but you're giving 40% oxygen. So now I'm going to say, I'm going to go down just a little to 35. I think that will make me happy with his PO2 and his SAT because he's an oxygen responder. I know he's an oxygen responder because I have his P to F ratio. P to F ratio less than 250 on 40% or greater FiO2 means your patient's not responsive to oxygen and you need something else. Now you can also see that he's gotten a little bit more acidotic just while we've been talking. So what we're going to do is we're going to increase his volume to 400. I'm not looking at an ARDS net predicted body weight program. I'm just setting that. And we just want to see what happens as I put that up to 400. And you can see, first of all, that his PCO2 has dropped a little and his pH is up a little, but I'm not really happy. So I am now going to increase his respiratory rate to 18, which is totally acceptable. So I've increased his tidal volume and his respiratory rate. And you're going to hear that start to change here. And you see it change. He's breathing a little bit faster. And he's breathing a little bit higher tidal volume and exhaling a little bit more tidal volume. Okay. So this is his tidal volume in mils per minute. This is his, what we would call alveolar ventilation. Actually, here is the overall ventilation. This is exhale tidal volume also over a minute's time, inspiration and expiration. He's breathing in the same amount that he's breathing out because he's a simulator, not a real human being. So he's breathing in at over a minute's time, 5.27, out over a minute's time, 5.27. But his total minute ventilation is 6.73. And that's pretty low. But now look at his blood gases. Okay. So now his pH is normal, his PCO2 is normal, bicarb normal, base normal. PO2 is a little bit high, doesn't need to be that high. So again, I'm not going to allow a lot of time to go by. I'm going to ask for his FiO2 to be reduced because I don't want his oxygen so high that it's going to cause him a problem. So I've gone down on his FiO2, and now you should start to see that his PO2 will come down a little bit. Not going to come down profoundly because it's still a percent that's higher than the FiO2. But this is a normal patient without respiratory effort, okay? So tidal volume in and out, flow in and then out. When we're flowing gas in, you reach a peak inspiratory pressure. That correlates over here to a peak inspiratory pressure of 16. You can see that here on the graphic, it's around 16, and it's reading at around 16. Okay, so that's a nice normal patient without effort. Okay, so now I'm going to say my patient is going to have respiratory effort. And when you see that, you'll see that all these dynamics have now been populated. And I'm going to confirm that. Things might change a little bit now because he's working a little bit harder to breathe. He did something right here that is really important. So I'm going to hold him here. You can see this. This is my ventilator breath. And then he took a breath on top of that. This is going to make your patient very agitated. So when you take care of a patient on a ventilator who's agitated, you should be looking at the vent screen. You don't have to be an expert, but you can see that 1 hump is normal, 2 humps is not. This is dysynchronous. It creates the feeling to the patient that he can't breathe and that he's suffocating and he's going to become anxious. He's going to have sympathetic discharge, high level of circulating catecholamines, and ultimately that's going to wear him out. Now you can see now that he has muscle effort and his airway pressure, which is 6, right? Centimeters and water pressure is 6. And now he's starting to have a little bit more muscle effort. You can see that up here. Okay. All right. So by the way, I don't go in there and say, let me sedate my patient. What I want to do is talk with my therapist and say, how do I make my ventilator meet my patient's need? He's obviously struggling with the way that the gas is being delivered. So this is a simulator, so I'm limited to what the simulator is going to tell me to do. So he's exerting some effort. He's feeling like he isn't getting breath fast enough. He feels like he's not getting breath well enough. So one of the things I'm going to do is first I'm going to look at his peak pressure. So I want that peak inspiratory pressure less than 35. When it's less than 35 and I see this, the first thing I'm going to do is I'm going to say, I want to deliver his gas to him faster. So it's like the speed of your car getting to its destination faster. The definition for flow on a basic ventilator is 60 to 80 liters a minute. So I change it to 80 liters a minute. And I want to see if that actually improves. Okay, now remember, he's on a simulator, but now I'm flowing my gas faster. And what I'm actually seeing is he is now in respiratory alkalosis. Okay, so now what I'm probably going to do is I'm going to change this trigger to pressure. Right now it's on a flow trigger. And see, again, because it's a simulator, whether or not I can reduce this respiratory effort. Okay, so I'm not going to be able to do it because it's instilled on the simulator, but traditionally it's going to go back to less respiratory effort because my patient now feels like he is breathing better. He's not going to double stack. Okay, so I've gone back. I got to confirm that, sorry. So I've gone back to a normal breathing pattern. I adjusted the flow. I've gone back to a normal breathing pattern. My patient doesn't feel the need to pull so hard against the gas delivery of the ventilator, but I can still see here that I have some problems. Okay. So now that I'm giving him better gas flow, he's no longer dysynchronous with the ventilator. I'm now going to reduce his respiratory rate because he is now, of course, in respiratory alkalosis. So I'm going to put his respiratory rate back down and we're going to wait some time. And obviously a simulator responds well before a patient does, but you can see that his pH comes down and his PCO2 comes back up. So 3 things that are going to affect your patient's ability to take a breath when they're intubated: their tidal volume, which inherently we want to keep low, their respiratory rate, and how fast or slow the gas is being delivered to the patient. So I'm going to look at those 3 things, and you can see now I worked this out so that my patient had a much better blood gas. When you have patients who are persistently in respiratory acidosis with a pH that's low and who are dysynchronous with the ventilator, if you are attending my class, you want to hear what I have to say, you will also appreciate that you have eyes on that patient. You might not be an expert in respiratory therapy, nor do you need to be, but you have to advocate for the patient. Let your colleague know that your patient is struggling. And when they say sedate the patient, say, I'm happy to do it, but can we check the ventilator first? So now I'm going to go back down. I want you to look over here on the graphic side of the page where you're seeing volume, flow, and pressure. And look what happens as I go down on the flow. I'm going to go down to 60, which is the low limit of normal. That's the rate of speed of the delivery of the volume. So you see how the breath expands a tiny bit and the flow curve expands a tiny bit. Okay. And you see that now my patient has respiratory acidosis. I'm breathing too slow for him at a rate of 14, and the gas is flowing too slow. That's the flow rate. I can only increase flow rate, and you can't do it, but you can ask your therapist, if the peak inspiratory pressure is below 35. Peak inspiratory pressure is greater than 35. The lung is too stiff to push gas in quickly. Okay, so I'm going to go back up on the flow because I found that that was pretty great. I like that flow rate of around 80. Normal on our vents, all vents, 60 to 80 liters a minute. It's just whether your gas pedal's at 50 miles an hour, 60 miles an hour, or 80 miles an hour. You're going to get to the same point, but when you go at 80, you get there faster. Okay? All right, beautiful. So I try to set this up somewhat like how we see our patients here in our intensive care units at Grady. So now I'm going to make this patient have COPD. COPD lungs tend to be relatively compliant, but you can see the setting I'm on here is terrible for that patient, right? He has profound respiratory acidosis and hypoxia. So I'm going to treat his respiratory acidosis first, and I'm going to do that by increasing his respiratory rate. So he has pretty significant respiratory acidosis. I don't have a lot of time to waste here, right? I need to be aware of what's happening. I have to be communicating this effectively. My patient's retaining CO2. His end tidal CO2 has gone up, and I need to adjust that. Now, look at what his peak pressure is here. I need to, because it's greater than 35, I'm going to reduce this flow rate. And I'm going to reduce it pretty significantly. That flow rate of 80 for him was not a good flow rate. So I'm going to reduce his flow rate. And let's see what happens. As I reduce this flow rate, I'm going to expect his peak pressure to come down. That's been alarming all day. You've been going in that room and putting a pause on that alarm all day and saying, I don't know what's wrong with this ventilator. I don't know what's wrong with my patient. Well, we're going to look at what's wrong. Okay. So now look at how much better my patient is doing now. Okay. So now his pH is 7.31, his CO2 is 50. Okay. So I have two things I could do. I can try to go up on his tidal volume. That may help. His lungs are usually quite distendable. So let me go up on the tidal volume. And as I did that, you can see that his PaCO2 comes down, his pH comes up. Now, most of the time, you're not trying to get those blood gases normal. But until you get that CO2 relatively normal, you can't deal with this PaO2. Okay? Now, he's intubated and on a ventilator. So, my friends, I am definitely going to go up on his FiO2 because he's on a ventilator. The only reason I don't want to give high FiO2 to a COPD patient is it knocks out their respiratory drive, but I'm controlling them. Okay. So I've increased his FiO2 and you can see he responded. Now, overall, what I'm going to tell you is I don't love that P to F ratio. I'd like that to be at 250. But in a COPD lung, I'm pretty happy if it's between 150 and 250. I'm only on 50% FiO2. But the other thing that we can do to increase oxygenation is we can go up on peak. So let's go up to 8. We're going to be conservative here. Now, take a look at what happens with your pressure. Okay, so your airway pressure moved from 5 to 8. This is where your breath begins and ends. You still get back to 0 before gas flows in, have that nice tidal volume breath. And by the way, It's 7 o'clock at night. I'm in charge of this patient. I'm the doctor. I'm the APP. I'm the respiratory therapist. I'm the nurse. I'm pretty happy. He's looking pretty darn great. So the thing that's really important for us to appreciate here is your therapist makes vent changes, but you've got to follow up. If it didn't improve his respiratory acidosis or it got worse, you need to call them right away. They're not looking at the blood gases every minute with their 40 patients or 30 patients. You've got 2, maybe you have 3. If you're in the ECC, maybe you have 5. You've still got to look at the blood gases with every vent adjustment. Okay, so now I'm going to change and I'm actually going to go to moderate ARDS. I'm going to confirm that. And with our current settings, what you're going to see is some changes that occur to our patient, okay, that I should actually be starting to affect his blood gases, certainly is affecting his pressure dynamics because now peak pressure is 32, okay. Now we're on 50% FiO2 with 8 of P, but now you see also his P to F ratio is 185. And now I'm going to add in severe acidosis, and that will be metabolic. So this is the sickest of the sick patients that you're going to see when you're taking care of patients. And you can see now you're looking at his blood gases. pH is 6.98. CO2 is 37. So this is not respiratory acidosis. This is metabolic acidosis. So his bicarb is 8. His base deficit is -15. This is a shock measure. You need to treat this with perfusion, not just mean arterial pressure, not just volume, but you need to assure perfusion. However, while you're getting people on the line, you're trying to make decisions about what to do, this patient's going to die, okay? So we've got to, first of all, try to assist our patient to compensate for his metabolic acidosis. Remember, there's only 2 rooms in the blood for acid. Hydrogen ion, which is metabolic, carbon dioxide, which is respiratory. Let me get rid of some respiratory acid because with a pH like this, with the metabolic acidosis, no matter what you do, you're not going to be able to get his mean pressure up. So meanwhile, you're fiddling around, you're at 10 of Levophed, you're at 20 of Levophed, you're stable on your vasopressin, you're at 5 of epi, you're at 10 of epi, you're at 30 of norepi, you're at 10 of epi, you're at 40 of norepi, you're at 50 of norepi. And by the way, his base deficit is going to get worse, not better, because he can't respond. Remember, the number 1 cause for profound refractory hypotension is metabolic acidosis with a pH of less than 7.25. Now, that's not going to be true with DKA, but it is true with hypoperfusion acidosis. So meanwhile, I'm talking, my patient's organs are failing. So first and foremost, I need to get rid of some of that CO2. And especially if I'm going to give him bicarb, because bicarb dissociates into CO2. So I'm going to increase this respiratory rate. I want to blow off some of that CO2. So you'll see as the CO2 starts to drop, that pH is going to come back up, okay? I'm not going to be able to treat his metabolic acidosis with the ventilator. I just want to get his pH up, okay? Now, remember over here is his peak pressure. So I'm feeling like I might be able to increase his flow rate just a bit. I don't want that peak pressure above 35, but I'm going to watch it. I've increased his flow rate. I'm watching what happens. In the meantime, I need to be working on perfusion. I probably need to hang a bicarb drip, okay? And then I'm going to, although I might not want to do this really, with a simulator, I am going to do it. I'm going to increase his tidal volume. So what I'm now bringing him to is a minute ventilation. That's tidal volume times respiratory rate of 10.44. Finally got his pH up to 7, okay? All right, I feel good enough to walk away, to go get a bicarb. I give him bicarb, and when I give bicarb, I have to be aware that bicarb is going to dissociate into CO2. So I need to be able to have somebody with me that's going to help me manipulate my ventilator to help me do better for my patient. Okay, so I have to treat his metabolic acidosis with perfusion. Vasopressors don't enhance perfusion. That means when you have somebody that's this severe, you need to be looking at blood gases every 2 to 3 hours. You need to be looking at blood gases after every intervention to see what you've done and are you going in the right direction. Okay, so I'm going to put him back to a moderate acidosis now. And you feel so much better. Okay, things have gotten a little bit better. Oh, all of a sudden he's responding to my vasopressors because now my pH has gone up and his receptor sites can respond. And now he's actually enhancing his vascular tone, looking a little bit better. He's not working hard to breathe. The ventilator is working hard to breathe for him. Okay. Now, we're feeling pretty good. We're doing what we can. We're trying to give volume. Maybe we give an inotrope. Maybe we're giving blood. We're trying to enhance his perfusion. And we only know if we're improving perfusion by seeing if the bicarb and the base get better, but I can't do that here. So now I'm going to say whatever therapy we're giving him is making him a little bit better in terms of perfusion. I can't fix that with the ventilator. I can just compensate for his acidosis and I can correct respiratory acidosis, but I cannot make metabolic acidosis better with a ventilator. But now he's looking just a tad bit better. Okay. So now I say, all right, I don't need to breathe him this fast because that's really can cause some stress injury to the lung. But first, before I go down on his rate, I'm going to go down on his volume because I don't want to overdistend his lung. So we're going to see, I went back down to 400. Hopefully, we'll still be able to maintain a relatively normal PaCO2 and a relatively normal pH. I don't really want to be on the alkaline side of 7.4. I'm okay to be down on the acid side of 7.4. I would wait 30 minutes, an hour. We're doing it quickly because we're doing it with a simulator. Okay. And then I'm going to say, okay, I'm still pretty good here. I'm going to go down on his respiratory rate. So when I go into the SICU here at Grady and I see patients being breathed by their ventilator 26, 27, 28 times a minute, 25 times a minute, I say, why is that? Well, it was compensatory for metabolic acidosis. We look at the blood gas. Patient doesn't have metabolic acidosis anymore. You treated that. Now he's in respiratory alkalosis. So, right, this is dynamic. It is always, always, always changing. Okay, well, we say, okay, we're pretty good. pH 7.36. I've titrated my norepinephrine. It's now down to 12. My epinephrine is 4. I'm on standard vasopressin. I'm feeling pretty good. My perfusion seems a little bit better. Things seem okay. Yes, I'm a little bit acidotic. I'm going to be kind of okay as long as that doesn't drop down to 7.25. I'm going to be okay. But the next morning when I come, I see some other changes. And those other changes are what can happen when we're not cautious with our ventilator. Our patient now has severe ARDS. So peak pressure is high, oxygenation is low, and that poor oxygenation is going to feed the metabolic acidosis. His respiratory acid is being regulated quite beautifully. He's not oxygenated. So what's the first thing I want to do? I want to look at this and say, this P to F does not appear to me to be responsive to oxygen, because typically you need to have a P to F of greater than 150. That's the PO2 divided by your FiO2. That's what your docs talk about all the time. FiO2 is in the decimal. So by the way, what I as a nurse can do is hit the 100% suction button while I'm waiting for someone to come. So I'm going to do that. But my patient's not an oxygen responder. My therapist is going to come and he's going to say, I'm going to go up on his PEEP. And they're generally going to go up kind of high on that PEEP. So we're going to increase our PEEP. Okay. And your therapist is also going to say, in the meantime, whether or not we think he's an oxygen responder, let's put him at 100% FiO2. So you don't just increase your FiO2, you've got to increase your PEEP. Okay. Look how quickly that patient responded from both, not from one, from both. But look, his PF ratio really isn't much better because we haven't made his lungs better. What we've done is we've improved his usable oxygen and his bound oxygen, but we really have not improved the situation for the patient, okay? He's really struggling and he's a little bit in trouble. So I'm pretty happy right here. I'm probably going to say myself, let's sit for a bit and let's kind of see how things are going. Okay, I'm not totally happy with this, but I can't go up on my tidal volume because my peak pressure is high. Okay, so because my peak pressure is high, see, just watch what happens when I put more volume in, right? My peak pressure is going to go up higher. And it's continue to go up higher. See what happened to that peak pressure? You're going to overdistend your lung and you're going to cause lung injury. So actually what we do in this circumstance, when our peak pressure is high, we're going to reduce the tidal volume. So remember, we were at around 400. I'm going to go down to 360. I want to reduce that peak pressure. I'm going to see that the PaCO2 is going to go up because my tidal volume went down. So PaCO2 is going to go up. As my tidal volume goes down, we'll have to wait a second. And it's going to start to climb, that PaCO2. And what I'm going to tell you is I'm going to accept that. I'm going to accept a higher PaCO2. That is called permissive hypercapnia. Okay, so it didn't really go up very much, and that's a very happy thing. Peak pressure is affected by flow. Watch what happens when I go up on my flow. And I'm just going to the high flow that I normally can do, the high-end flow. Hopefully the simulator will behave the way it should. When I go up on flow, my peak pressure goes up. So I've got to reduce my flow. Can't be at a normal flow, which is 60 to 80, because my peak pressure is up. So I'm going to go back down on my flow. And I'm going to keep my tidal volume low. And what that's going to mean is that my patient is going to start to retain some CO2 because I'm going to be hypoventilating him. As long as he does not become refractory, and he won't because it's respiratory acidosis. It's not really metabolic acidosis now. It's more of a respiratory component. As long as he doesn't have refractory hypotension, I'm going to accept this carbon dioxide and that pH. But if he loses the ability to respond to vasopressors, I'm going to have to do something about it. So I'm going to be okay with where I am right now. I'm not in love with it. I'm going to be okay with it. Well, the next day, a new doctor in town comes and he says, I'm really unhappy with this. You're giving him 100% FiO2. His PO2 is 96 and his PF ratio is 96. 96 divided by 1. I want you to go up on the PEEP. So we go up on our PEEP to 15. And immediately you see your patient has a better response. We're opening up more lung. His peak inspiratory pressure went up as well, okay, because we've got more PEEP in there. So now what I want to do is I'm going to measure. All you do on your vent, and your respiratory therapist will do it. It's a hard key at the bottom of the vent. It has lungs that are expanded with like an X or a line through it. That's called the inspiratory pause. I'm going to give my patient now an inspiratory pause of about 1.5 seconds. Now, because it's a simulator, it's not going to just do it once. It's going to do it continuously. But on your vent, it's only going to happen once. So the breath goes in, and then it is trapped, and it's not allowed out for 1.5 seconds. That's your plateau. Okay, so I'm going to look at that plateau, okay? And you can see now that your plateau pressure appeared over here. Your P plateau pressure on the settings that you are currently on are 34. Now, what this is, guys, is so important, is that the expiratory valves have closed. We've trapped gas in the functional lung, and we're looking at the corresponding pressure. Plateau pressure of 34 is dangerous. Plateau pressure should never be above 30, and normal plateau on a ventilator is less than 25. So we're at 35. We have a high peak pressure. Okay. So a couple of things that we're going to do. A couple of things that your docs are going to think about. And remember, this is a simulator. So I'm trying to show you responsiveness. And by the way, this is a beautiful simulator and it's very, very responsive. We're going to go back into our normal ventilation pattern. I'm going to turn off my inspiratory pause because remember, you just press it and it only occurs one time. But I want to see that I have a plateau pressure of 34, that I had a plateau pressure of 34. And so that's a really important concept, okay? So one of the things I'm going to think about here is that I'm actually going to reduce my flow, which means that I'm going to take a longer time to breathe in. And I'm going to change. And I'm now really, although it's not going to change it here, I don't think. Oh yeah, good. I now have changed to pressure control. Okay. So what I want to see is I made that change to pressure control. Let's see what happens. My expectation, my hope, and my belief, because I've reduced the flow and taken a longer time for my patient to breathe in, is that my oxygenation will stay the same or improve. And I don't want my pH to reduce. Okay, so as long, again, as my patient doesn't have refractory hypotension, I'm going to be okay here, okay? I may actually need to put my patient on a bicarb drip to compensate for their acidosis because I'm allowing them to retain CO2 while I'm opening up their lung. I've opened their lung with PEEP of 15 with a prolonged inspiratory time. Expiratory time has been lessened. Inspiratory time has increased. And I've done that because I changed the flow rate. So that's why you no longer see flow rate because I made that change. That's telling you that now you've got prolonged inspiratory time. And you can see that pressure gradient. And you breathe in and then out. And look at how that flow pattern has changed. Okay, so let's go back. Let's look again at volume control. Let's look at flow of 60. And our pattern, probably like so. Okay. Got confirmed. Okay, so you see the difference. You can hear the difference. And you can see the difference. This is with prolonged die time. So inspiration takes a long time. That helps me open the lung. You can see that when I went back to volume control, my PaO2 and my SATs dropped. When I went to pressure control and changed the flow rate, prolonged the inspiratory time, I recruited more lung and I better oxygenated. Okay, so the lesson here, and we're going to end here, is something that's really important to you is to remember that the peak inspiratory pressure is telling you something. Resistance to gas flow into the lung. It might be in the mouth because they're chewing the tube. It could be in the airway. They have a mucus plug or they're hyperinflamed. The tube could be in the wrong position, or because your alveoli are de-recruited. When that peak inspiratory pressure alarm goes off, it's not there for you to silence. It's there for you to know that something is wrong. The things a therapist is going to look at is your patient synchronous or dysynchronous? What is the tidal volume? What is the flow? And what is the pattern? Because I've got to get that peak pressure down. If the patient's not chewing on the tube's in the right space, there's not a mucus plug. This is about the alveolus. Your therapist will always do an inspiratory pause. What that allows you to do is look at the pressure in the lung when gas has gone in but has not been allowed out for a very short period of time. You're now looking at the pressure across the functional lung, the alveoli. That pressure should always be less than 25. Peak pressure should be less than 35. And if I put you on pressure control ventilation, I'm typically going to set your peak because that's what we're going to control. And that is completely related to the time of inspiration and your flow pattern. That's all it is. When I put you on pressure control, that becomes a time cycle for inspiration. It's just about how long we're going to flow that gas in until we reach the pressure that was preset. But our responsibility is to collect these blood gases and to try to do the right job to make sure that our patients are going to look better and to treat them so that they look better. And that correlating your blood gases is important to remember. You can treat ventilation and oxygenation with your ventilator. You can compensate for metabolic acidosis with your ventilator. And by the way, this is what a normal lung would look like on 100% FiO2. You'd have a PO2 of 398, 400, 450, a P to F ratio of 400, and that right away would say, you don't need to wait for anybody. You got to call respiratory therapists. They're going to drop that patient's PO2. Now, they might do it slowly. I would probably do it pretty quickly. And I'm also going to drop the P because that can also be pretty dangerous. I'm going to go down to 8. That's what we use here as physiologic. I'm going to continue to look at my patient. I'm looking at his SAT. He does not need 100% SAT. So if he maintains 100% SAT, I'm going down on the FiO2, and I'm now going to go down. I'm going to be aggressive. And I'm going to go down on FiO2 to 50. Really, quite literally, you don't ever need more than an hour to evaluate what the ventilator change you made had an effect. And really, just about every ventilator change you make, you're going to see within 30 minutes. My friends, it's your responsibility to make sure that we are not overventilating, that we are adjusting the ventilator to meet our patient's needs. I'm so sorry. So this was class 1 in ventilator simulation. I hope you enjoyed it. I'm really happy you came. I'm going to stop recording now, but I will be available to answer any questions. Thank you so very much. Bye-bye for now.